faculty and students. Welcome to today's clinical case discussions. We have 4 interesting cases from Department of ENT, Neurology, Dermatology and Cardiology. We'll start the session with the first case, Beyond the Ordinary, a case of fibrous dysplasia from Department of ENT, presented by Dr. K. Tejasri, moderated by Dr. A. Anusha.
Good afternoon everyone. I, Dr. Tejasri, second year postgraduate from the Department of ENT HNS, and my moderator Dr. Anusha, Associate Professor from Department of ENT HNS. Today I am going to present a case of Beyond the Ordinary, a case of fibrous dysplasia. Chief complaint: a 33-year-old female patient presenting to ENT OPD with chief complaints of left-sided nasal obstruction since 1 year. History of presenting illness: complaints of left-sided nasal obstruction since 1 year. Initially partial and continuous, progressed to complete and continuous, and there are no aggravating and relieving factors. Complaints of blurring of vision since 4 months, and complaints of swelling over the left jaw since 4 months. And there is no history of allergic symptoms, mouth breathing, snoring, postnasal discharge, facial pain and headache, and no history of other ear and throat complaints. Past history is nil significant, family history also nil significant. Personal history: patient consumes mixed diet and bowel and bladder are normal. General examination: patient was moderately built and nourished and well oriented to time and place and person, and vitals are stable at the time of examination. Local examination: nose. External osteocartilaginous framework shows no deformity. Dorsum of the nose and vestibule are normal. Tip test shows no caudal deviation. Anterior rhinoscopy shows nasal mucosa pale on both sides, nasal septum deviated to right, nasal floor normal on both sides, inferior turbinate shows hypertrophy on right side and normal on left side. Posterior rhinoscopy: posterior cornea are normal on the both sides, posterior end of inferior turbinate is hypertrophied on the right side and normal on left side. Posterior end of middle turbinate are normal on both sides, and eustachian tube of auricle is also normal on both sides. Functional tests: cotton wool test shows decreased movement in left side, cold spatula test shows decreased fogging on left side, Cortis test shows no improvement of nasal airway on left side. On examination:
Excuse me, you are writing your test. This is not an ENT conference. This is for normal audience. Therefore, they can understand part 2, but not the third one by everybody. You must tell what it is and what is meant for it.
Sir, functional test, cotton wool test, we take the cotton.
That's over, last one.
Cortis test. We'll take the cortis and we'll show ask the patient to breathe, sir, and they will show no improvement over the left side. On examination: face, a hard swelling of size 2 into 2 centimeters noted over the left side of the body of mandible, and there is no local rise of temperature and tenderness over the swelling. Clearly, on the right side, as the microscope was passing easily, and we can appreciate the structures of septum and inferior turbinate and middle meatus, and reaching freely up to the nasopharynx without any obstruction. When we see about the left side, here we can see the endoscope passing up to an extent and not moving up to the nasopharynx as it was due to obstruction. Ophthalmology referral was done as the patient complains of blurring of vision, shows fundus normal at the time of examination and no signs of optic nerve compression, and they advised Google. Provisional diagnosis shows left nasal mass under evaluation. Then CT scan was advised.
Is a coronal CT scan patient bone images showing heterogeneous groundless attenuation seen involving left ethmoidal fold extending to left frontal sinus and left sphenoidal sinus, and there is also expansive isolated lesion involving left hemimandible extending from the ramus to body. These represent fibrous dysplasia.
Left nasal mass and evaluations. Left nasal.
What is the original? That should come.
Original.
What mass? What mass? That is correct way of perceiving that.
The question is it a universal mass or a hard mass?
Hard mass. Don't look at it.
What is like this?
What the patient accept? And profile picture. Because you said something in the
Yes.
no profile picture.
I'm not kept in the CPC. I'm not kept in the CPC presentations.
But you describe.
Yes, sir.
Therefore, you must select that as an instructive point. And I have done the excellent manual. So we work for PNS CD.
No, sir.
Yes, you have a facial examination.
Yes.
That's a profile, sir. Only that manual has a spelling, background nothing, absolute normal.
I will have shown that picture. Basically. The teeth are normal.
Theta.
You're not seeing.
Yes, theta no. MRI of paranasal sinuses.
This is an excellent MRI paranasal sinuses images showing expansal bony lesion which appears hypopigments on T1 and T2 images seen involving left equatorial bone extending to left frontal sinus and left hemisphenoidal sinus. These patients show fibrous displacement.
And we have managed the patient with endoscopic sinus surgery under GA.
So we can see a hard structure in the middle meatus, which was felt like a turbinate, but when tried to cut, it was very bony hard. So we used drill here, and usually the ethmoid bone is a papery thin bone. Usually we plug the mucosa and bone with the forceps, but it is very hard due to the replacement of fibro-osseous tissue due to the altered osteogenesis, and this mass is being extended laterally up to lateral medial border of the orbit, that is lamina papacia, and keeping maxillary ostium as intact and landmark, we drilled posteriorly to reach sphenoid sinus, and where the mass bulk lesion was removed from the sphenoid sinus as the mass was being compressing the optic nerve. To reduce the pressure, we have used high speed drill to remove the hard bony mass here.
Postoperative care. Patient was treated with antibiotics for 4 days, followed by oral antibiotics for 5 days. Nasal packs were removal done on POD 2. Endoscopic cleaning done, and patient was discharged in stable state on POD 4. The excised tissue from the left nasal cavity was sent for biopsy.
This is a focused photomicrograph with 10x magnification showing branching and anastomosing irregular curvilinear trabeculae of oven bone, and the intervening stroma showing bland spindle cells. A 20x magnification shows loss of osteoblastic premium. These features are suggestive of fibrous dysplasia.
Biopsy report shows histological features are suggestive of fibrous dysplasia. Final diagnosis is fibrous dysplasia of ethmoid. Postoperative END. It is done after the 2 weeks of the follow-up, and here we can show a healthy healing mucosa, and we can see the patent osteums or openings can be noted over the frontal and sphenoid. Openings are clearly noted. Healthy healing mucosa was noted.
Before that, I got a small question and doubt. Fibrous something bone lesion. Number one, there is a hard lesion in the mandible of the body, and your rhinoscopy or endoscopic examination in the heart. Has it been done into simple but functionally normal X-ray of the sinuses as well as mandible? Not done. Cannot be diagnosed or if there is a requirement to know something to be done. Therefore, we had an idea that the mass is obstructing from beginning and causing some sinus problem.
I think X-ray is a better thing for that.
No way. Clinically. Your clinical diagnosis is the sinuses are not draining and obstructed or is feeling of obstruction.
No, it's clinically you're asking or you're asking by investigation?
Clinical question.
He doesn't have any symptoms.
That's the question. That clarification. Because when there are no question of obstructive component and there is a mandibular swelling of that nature, you should correlate with the simple X-ray and then go for further.
Why X-ray? Why X-ray? We have a mass reading and as we can.
Therefore, there are two masses of say.
The CT will give entire picture, right?
They should be evaluated what different, is it related or unrelated?
Obviously, CT is better to know where from they are arranging it other than X-ray. Unless and if just for the academic purpose you want to document and take X-ray, accepted. The functional purpose, patient has no. There is no role for X-ray.
My question, radiology. Fibrous dysplasia cannot be diagnosed on plain X-ray?
No.
Yes or no? Radiology. Because the entity of fibrous dysplasia is recognized 200 years or 150 years by Albert and so on board.
Then why you are using ventilator, sir? You can treat the patient with ambu bag, right?
Don't conclude this way because you have no systematology of rhinology, obstructive component. We found out a solid mass. Why I am asking that question is fibrous dysplasia can be recognized. Next, when to operate or not to operate, that decides. Not the diagnosis after operation. That is the question. We have to diagnose prior to the fibrous dysplasia can be recognized by plain X-ray because it was the first thing to be before the advent of CT. 70 years before fibrous dysplasia was classified and made everywhere.
So we will go into the treatment, sir, from now onwards.
Both are you are correct. Fibrous dysplasia can be diagnosed easily and the radiograph, but the lesion is skull bones and multiple involvement. So there is obviously a overlap. So as he rightly said, the X-ray will be very beautiful and academic purpose, but eventually you might require even without surgery, even without doing planning for surgery, you might require CT scan for the confirmation. The mandible lesion would be very clear in the plain radiograph because of lack of overlap, but the lesion within the paranasal sinus will be confusing because there will be a lot of overlap between anterior to posterior. So eventually you would require the CT scan.
Yes. Point is now have you documented the sinus dysfunction? Have you documented ophthalmic dysfunction?
This is the optic nerve area, sir.
Yeah.
What exactly? When you compare to this one, see the amount of compression that is getting over there. Almost 360-degree compression over there. So you want us to wait till the patient lose the sight, then we can document it.
No. My question is not that we are misinterpreting it. One, it can be made out early fast by the plain diagnosis, and but there is a symptomatic component where the involvement of surgery as documented by clinical optic nerve involvement or associated. Then you can. I am not denying it. Instituting and go in PET scan or that is a different issue. My question is that only. You said yourself that there is no rhinal obstruction and there is no evidence of optic nerve involvement.
Yes, nasal obstruction is there. The macular sinus has the retention sinus at least. You can see there.
Why? Because the fibrous dysplasia or
can you see this one, sir? Vishwa, sir. Can you see this one?
Yeah.
Now there is some retention in the macular sinus on there. Right?
Yes. What is symptom that it caused later? You told me.
Pardon?
What is the symptoms of that?
Patient complained with nasal obstructions.
Isn't it enough? I first చెప్పినారే కదా చెప్పించారు.
Discussion. Fibrous dysplasia is a benign fibro-osseous disorder in which normal bone is replaced by abnormal fibrous tissue and immature oval bone. Estimated prevalence is about 61 cases per 10 lakh persons. It accounts for roughly 5 to 7% of all benign bone tumors and lesions. Fibrous dysplasia may be monostotic or polyostotic. Isolated involvement of ethmoid sinus are uncommon. Clinical presentation depends on extent of disease and may include headache, nasal obstruction, facial swelling, proptosis, diplopia, or maybe incidental. Important differential diagnoses are ossifying fibroma, osteotoma, cemento-ossifying fibroma, and other fibro-osseous lesions of sinonasal tract. Surgical treatment is indicated for symptomatic, progressively cosmetically deforming or functionally compromising lesions. Endoscopic excision or debulking may be appropriate for selected ethmoidal lesions. Long-term follow-up is important because of possible progression, recurrence after incomplete treatment, and their possibility of malignant transformation.
Of Neurology presented by Dr. Hema and moderator is Dr. K. Vamshikrishna.
Department of General Medicine. Today I am here to present a case from Department of Neurology. This is a case series of bilateral thalamic lesions titled A Tale of Two Thalami. Before going into the actual cases, we'll go with the introduction. Bilateral thalamic lesions have a relatively focused differentials. It can be due to vascular causes, that is arterial and venous, infections, metabolic bad toxic, neoplastic, inflammatory or demyelinating, degenerative and other causes. Vascular causes, it can be due to arterial infarct. Typical clues to diagnosis include bilateral paramedian thalamic infarcts without the involvement of rostral midbrain, altered consciousness and vertical gaze palsy. In the vascular, second is deep cerebral venous thrombosis. Clues include bilateral thalamic edema or infarction, often hemorrhagic, with presence with headache and raised intracranial pressure. Third one is a top of basilar syndrome, which includes thalamus, midbrain or occipital or temporal involvement. Infectious causes, which includes Japanese encephalitis, which involves bilateral thalamic with or without the involvement of basal ganglia, brainstem, presence as fever and encephalitis. Western encephalitis, which involves the thalamus, basal ganglia and brainstem. Tuberculosis, presence as tuberculomas or meningoencephalitis involving the basal ganglia or thalamic involvement. Viral encephalitis, which involves particularly the flaviviruses. Other includes inflammatory or demyelinating causes. Acute disseminated encephalomyelitis, where typical clues are multifocal bilateral lesions, often after infection or vaccination. Other demyelinating disorders, which are NMOSD, neuromyelitis optica spectrum disorder, and MOGAD, myelin oligodendrocyte associated disease, can involve deep grey structures including thalami, clippers and other autoimmune encephalitis, which includes variable involvement. Other causes are neoplasms, primary CNS neoplasms, which involves deep grey or thalamic lesions, often enhancing. Gliomas or bithalamic gliomas, infiltrated by thalamic lesion by thalamic enlargements. Other include prion diseases, which is Creutzfeldt-Jakob's disease, which has a characteristic pulvinar or hockey stick sign. Rapidly progressive dementia with myoclonus. Others include Farr's disease or calcific disorder, bilateral calcifications rather than acute diffusion restriction. We'll go with the case scenarios. Case 1. A 49-year-old postmenopausal woman who is a homemaker by occupation came to neurology OPD of Dr. SIMS&RF with chief complaints of sudden onset of memory disturbances and increased sleep 15 to 16 hours per day since 2 days. She has a risk factor of uncontrolled type 2 diabetes mellitus. This is the lab parameters. Everything is normal except the HbA1c, which is 11, and elevated total cholesterol and triglycerides. Triglycerides was 34, HDL was a bit lower, it is 33, and vitamin D3 is lower, it is 10.2. Today echo was within the normal limits. Carotid Doppler was done, which shows mild erythematous disease involving bilateral carotid arterial system. Fibrofatty plaque seen in right carotid bulb causing 15 to 20% of luminal iron. MRA brain.
Is an axial MR flare brain image showing hyperintensity involving bilateral thalami. It's a case of acute infarct involving bilateral thalamus.
Acute subacute infarct seen involving the bilateral thalamus extending into midbrain on both sides. Chronic lacunar infarct seen in left capsuloganglionic region. Mild diffuse cerebral atrophy. Case 2. 65-year-old postmenopausal woman who is a homemaker by
Previous phase. Are there any correlation to the brainstem involvement of midbrain to your clinical findings?
Yes, midbrain there is
Anatomical and clinical correlation. Only infarct of the brain is seen rather than clinically evident. That's my question.
no clinical evidence of midbrain.
There is no clinical evidence. There is no vertical gauge palsy. It's only pure bilateral thalamic presentation. Yeah, but there is infarct in that rostral midbrain. There is no clinical.
Why I asked that question is which part of the midbrain doesn't have a clinical manifestations unless
Second case, a 65-year-old postmenopausal woman who is a homemaker by occupation was brought to emergency department with chief complaint of excessive sleepiness since 2 days. She has a risk factors like history of coronary artery disease for which she is incompliant to medication. She is known hypertensive and she is obese. Clinical examination revealed excessive drowsiness and there is vertical gaze palsy. Her blood picture was within the normal limits. Even the lipid profile was within the normal limits. Ultrasound was done, which showed mild increased hepatic parenchymal echo texture and small umbilical hernia. Carotid Doppler, there is no evidence of hemodynamically significant stenosis seen in the present study. 2D echo was also normal. MRI brain.
This is a DWI of brain showing restriction diffusion involving bilateral thalamus. It represents acute infarct.
Acute infarcts are seen in bilateral thalama and right side of midbrain. Chronic infarcts seen in the right cerebellar hemisphere. In this case, due to the involvement of midbrain, as midbrain is a center for vertical gaze, there is vertical restriction of the vertical movements, there is vertical gaze palsy. Case 1 and 2, the diagnosis was artery of Percheron infarction. Artery of Percheron. The artery of Percheron is a rare anatomical variant in which single perforating artery arising from the proximal posterior cerebral artery, usually the P1 segment, supplies both paramedian thalami, often with additional supply to the rostral midbrain. This is the artery of Percheron infarction. Occlusion of the single artery produces the characteristic pattern of bilateral paramedian thalamic infarction with or without midbrain involvement. This is the usual blood supply of the thalamus. This is the anterior. This is the anterior thalamus, posterior thalamus, medial and lateral thalami. Anterior thalamus is supplied by the tuberothalamic artery, which is a branch of posterior communicating artery. Lateral thalamus is supplied by the thalamic geniculate artery, which is a branch of P2 segment of the posterior cerebral artery. Posterior thalamic is supplied by the posterior choroidal artery, which is also a branch of the P2 segment of the posterior cerebral artery. Medial thalamus is supplied by the paramedian artery, which is a branch of P1 segment of the posterior cerebral artery. This is the artery of Percheron, which is an anatomical variant of posterior cerebral artery. Usually it is from the P1 segment. It is supplying both the thalami along with the part of the midbrain, rostral part of the midbrain. In the artery of Percheron infarct, we have the classical clinical triad, altered level of consciousness, which is drowsiness, hypersomnolence and coma, along with the vertical gaze palsy, particularly impaired upward gaze and memory impairment. Case 3, a 30-year-old woman who came to the pulmonology OPD with chief complaint of shortness of breath, dry cough, chest pain since 1 month. She has a complaint of memory disturbances since 7 days, for which neurology referral was done. On examination, she has a recent memory was decreased, recall was decreased, she is unable to remember what she has eaten for the breakfast. Fluency is decreased, bilateral eye were normal fundus at the time of examination. Her blood picture. ANA profile was negative and TSH was within the normal limits. Anti-CCP and rheumatoid factor was done due to a suspicion of systemic involvement. These are within the normal limits. Ultrasound abdomen and pelvis was done, which revealed hepatomegaly. Hepatic veins and IVC appears prominent. Mild right pleural effusion, moderate gross left pleural effusion, and mild ascites. 2D echo was done, which is within the normal limits. MRI brain.
These are explanatory and DWI images of brain showing multiple foci of blooming involved, which represents hemorrhages seen involving bilateral thalami. And there are mixed areas of vasogenic and cytotoxic edema. On MR venogram, there are multiple deep cerebral veins in venous sinuses thrombosis noted. So these could represent hemorrhagic venous influx of bilateral thalami.
Multiple deep cerebral veins and venous sinuses thrombosis noted, which is acute CSVT, cerebral sinus venous thrombosis. This is leading to hemorrhagic venous infarcts of bilateral thalami. Diagnosis: venous infarction of bilateral thalami. Case 4, metabolic causes. A 46-year-old female patient presented with a bilateral lower limb weakness of on post-operative day 7 of laparoscopic appendicectomy. Risk factors: she has a decreased food intake since 1 month in view of pain abdomen and absent food intake since 1 week. On CNS examination, patient has downbeat nystagmus, ophthalmoplegia, ataxia, confusion with visual and auditory hallucinations. Her blood picture was within the normal limits, RFT was within the normal limits, serum electrolyte sodium was 130, which indicates mild hyponatremia. In LFT, only ALP was elevated, which is 126. Her thyroid profile was within the normal limits. ANA profile was negative. Anti-TPO was 0.19, which is normal. Serum NMO and serum MOG were done, which was negative. CSF analysis was done. Glucose was 66.8, protein 31.56, LDH was 15.9. ADA was also negative. Cells were 1 cell per cubic millimeter. All of the lymphocytes, gram strain and AFB are negative. Serum vitamin B12 was 503, which is within the normal limits. Creatine kinase was also within the normal limits. MRI brain.
This is the DWI image of brain showing restriction, diffusion restrictions in involving medial aspect of bilateral thalami. It's also seen involving mammillary bodies and rectal plate in periaqueductal area. Could be Benneke's encephalopathy.
Intraxial T2 weighted or flare hyperintensities with mild restriction of diffusion seen involving medial aspects of bilateral thalami around third ventricle, mammillary bodies, rectal plate and periaqueductal area. Mild effacement of sulcal spaces could be due to any cerebral edema. Diagnosis of case 4 is Wernicke's encephalopathy. These are the 4 different cases with the different thalamic lesions. Common radiological significance but with different etiologies. First one is artery of Percheron infarct. Second image also is artery of Percheron infarct of 2 different patients. Third image is a venous infarction due to cerebral sinus venous thrombosis involving bilateral thalami. Fourth one is a Wernicke's encephalopathy, which is due to metabolic cause due to vitamin B1 deficiency, thiamine deficiency, which is involving the bilateral thalami. Clues for the diagnosis: bilateral paramedial thalamic infarction plus vertical gaze palsy plus altered consciousness. Strongly considered artery of Percheron infarction. Bilateral thalamic lesions plus mammillary bodies or periaqueductal involvement plus nutritional deficiency as a risk factor. Consider Wernicke's encephalopathy. Bilateral thalamic lesions plus fever or seizures or encephalopathy. Consider Japanese encephalitis or other viral encephalitis. Bilateral thalamic edema or infarction plus headache or papilloedema. Consider deep cerebral venous thrombosis. Pulvinar or rocky stick sign plus rapidly progressive cognitive decline. Consider Creutzfeldt-Jakob's disease. Thank you.
Under workup, sir.
She's under workup.
It's 10 days back it has been aspirated 10
Yes, sir.
twice outside once and inside once.
Yes, sir. It was a transidative fluid, thought of tuberculosis, but CBNAT was negative, sir.
Any workup for the vein?
Any pulmonary faculty can answer this.
Venous sinus thrombosis, any workup has been done?
Sir, we have systematic profile, ANA and all ANA profile was sent, which is negative. IgG4 is slightly elevated, sir. Still the patient is under workup.
Thank you.
Antiphospholipid report is awaiting, madam, or no?
Report is awaited, sir.
Antiphospholipid yes.
One question to the resident.
All the 3 vascular stroke, is there any comorbidities of diabetes or hypertension?
Yes, sir. First 2 arterial infarct patients are diabetics, sir. Diabetics and hypertension.
Both.
No, sir. First patient uncontrolled diabetic, sir, and second patient is known CAD with hypertension with obesity as risk factors.
First case they presented with reduced consciousness.
Yes.
They are sleeping. Case 3 and 4 they didn't present complaint.
Yes, sir.
Why they presented like that? It's a pathway.
Memory disturbances, patterns,
Memory is different from consciousness. Both are not same. Generally, the ascending rate passes above from the midline thalamic nuclei, sometimes the dorsolateral nuclei also, and it goes to the either prefrontal cortex or the parietal cortex. Some different theories are there.
They are not able to decipher and clarify, sir. Little louder and to audience side.
So the anatomical substrate for consciousness is the ascending reticular pathway arising from the upper pons. It crosses above.
It can be like diffusely distributed, not
Yeah. That's right. That's why the presentation is like this. These are not completely proven, but general accepted theory is the ascending reticular pathway from the upper pons through the midline thalamic nuclei or the dorsolateral thalamic nuclei process through the either prefrontal cortex or the parietal cortex. So this is the pathway involved. So that's why you are saying
the pyramidal connection. I mean, ultimately, like it goes to the prefrontal cortex. So it has an effect on this. Because the unilateral lesions won't cause this drowsiness. So whenever, like any patient coming to the casualty with altered sensorium, we should consider like one of the definitions is bilateral thalamic.
condition called as heart problem of consciousness. Of course, it is beyond neurology. Have you heard that?
Yes.
Heart problem of consciousness. Issue like that. Heart problem of consciousness. I mean, it's not in neurosurgery or neurology. The basic neurosciences, those who deal with basic neurosciences. Recently, in 2025, an article is published in Nature article. So, to deal with the heart problem of consciousness. So, because it's beyond our scope. So,
You are questioning about the consciousness center, or you are questioning about the anatomy of consciousness or the newer concepts of consciousness?
That's the problem, sir. That's what we don't understand. What is the subjective experience of the, what are the neural correlates of consciousness? So this is unanswered question yet. That has been labeled as heart problem of consciousness.
Previously we used to say like RAS system, all these things. But nowadays they say like everything comes on like networks. Like you have, suppose in neurology, whenever a patient comes like an altered sensorium, you should always think of whether patient is having bilateral cortical or brainstem or bilateral thalamus. That's only the coming like stem cell lesions or something causing the effects of this patient will be like unconscious. So it's in widely represented in broad.
It's a problem. And global neuronal networking theory, these are the proposed theories. These were tested 256 subjects. This is published in Nature journal. So why we feel the subjective experience of the networking phenomena. So why do we feel the redness of red, the warmth in warmness? But the subjective experience of the consciousness is a different aspect which has not yet been solved. So in that relation, this question comes, hard problem of consciousness.
This is Bullous Masquerade from Department of Dermatology, presented by Dr. Madhuri.
I am Dr. Madhuri, second year postgraduate from Department of Dermatology, Venereology and Leprosy. My moderator is Dr. Shweta Chaudhary ma'am, Associate Professor, Department of DDL. I am here to present a case of Bullous Masquerade, chief complaints. A 26-year-old woman presented to the dermatology OPD with fluid-filled lesions over the upper part of the body on and off for 4 months. Painful raw areas in the mouth with difficulty in swallowing for 3 months. Recurrent episodes of fever with mild cough and joint pains for 2 weeks. History of present illness. Patient was apparently normal 4 months back, first month she developed fluid-filled lesions with mild itching and pain over the genitals and thighs which healed spontaneously in 4 days. Second month, she developed fluid-filled lesions over both forearms and the oral cavity, for which she was treated with Cori antivirals at an outside hospital. The lesions on the forearms partially healed, but the oral ulcers persisted. Third month, she developed dysphagia to solids and liquids. Endoscopy revealed candidal esophagitis and erosive antral gastritis, treated with tablet fluconazole 150 mg for 15 days and tablet rabeprazole for 1 week, and the lesions resolved. Fourth month, she developed fluid-filled lesions, initially over the abdomen, bilateral upper limbs, axillary region, both thighs, bilateral buttocks, neck and face. No history of any new drug intake prior to the onset of symptoms. No history of photosensitivity or significant weight loss. She consulted a dermatologist outside and underwent skin biopsy. Biopsy features were suggestive of probable bullous pemphigoid. However, direct immunofluorescence was not done. She received tablet dexamethasone 20 mg twice daily for 45 days, tablet dapsone 100 mg once daily for 30 days, and supportive treatment. Partial response was noted, however, patient discontinued treatment. Course at our hospital. Patient presented with recurrent episodes of fever, cough and joint pains for 2 weeks. Patient was admitted under the Department of General Medicine for further evaluation. Patient was started on antibiotics, prednisolone 20 mg twice daily. Patient received 1 unit of packed RBC for anemia. Treated for hypocalcemia with calcium supplementation. Patient was referred to the dermatology department in view of skin lesions. Skin biopsy was performed and she was advised injection dexamethasone 8 mg IV once daily, capsule doxycycline 100 mg twice daily, antihistaminics and topical antibiotics. In view of progressive skin lesions, she was transferred to the Department of Dermatology for further evaluation and management. Presenting complaints at our department, she had fluid-filled lesions, red raised lesions over abdomen, trunk, neck, both arms and thighs with minimal itching, rupturing spontaneously in 1 to 3 days, leaving erosions. Erosions on tongue and lower lip associated with burning sensation while taking food. Both ankle and knee joint pains were persistent, but she did not have any fever episodes. No history of photosensitivity and no gastric and urinary complaints. Past history, she is not a known case of diabetes mellitus, hypertension or coronary artery disease, not a known case of asthma COPD, no previous history of CVA, chronic renal failure, epilepsy or tuberculosis. Personal history, appetite was reduced due to oral lesions, sleep, bowel and bladder and menstrual history is normal, surgical and family history was nil significant. General examination, patient was moderately built, moderately nourished, pallor present, vital stable, cardiovascular system S1, S2 heard, no added sounds, respiratory system normal vesicular breath sounds, per abdomen soft, non-tender, no organomegaly, nervous system no focal neurological deficits. Vitals at presentation, blood pressure was 120 by 80 millimeters of mercury, pulse rate 1 or 2 beats per minute, respiratory rate 16 counts per minute, temperature afebrile, SpO2 97% on romaine and GRBS 110. Mucocutaneous examination. Multiple flaccid and few tense bullae containing clear fluid on a background of urticarial rash, few coalescing noted over the neck, chest, abdomen, trunk, flexor aspect of both arms, forearms, bilateral buttocks, bilateral thighs and the anteromedial aspect of both ears. Nikolsky sign and Bulla spread sign are negative. So these are the cutaneous lesions, multiple flaccid and few tense bullae containing clear fluid on the background of urticarial rash. Bullae and erosions noted over the anterior aspect of neck and both upper eyelids. Few bullae, flaccid bullae on the medial aspect of the left arm. Oral cavity, few erosions noted over the lateral border of the tongue and the inner aspect of lower lip. Single vesicle noted over the upper lip on the left side. Few post-inflammatory hyperpigmented lesions over old lesions on bilateral groin creases, thighs, buttocks, upper limbs and abdomen. External genitalia, palms, soles, scalp, hair and nails all were normal. Provisional diagnosis, pemphigus vulgaris, and differentials were bullous pemphigoid and bullous SLA. Investigations, complete blood picture. Hemoglobin gradually increased from 7.8 gram percent from day 1 to 10.8 gram percent on day 12. Total WBC count increased from 7.9 cells per millimeter cube to 24.3 cells per millimeter cube on day 12. All parameters were normal. Liver function tests, except for slight increase in SGPT, all parameters were normal. Renal function tests were normal.
Previous slide, madam. The question is 7.9 grams, 8 grams, compared to 11 in 3 days.
She was transfused with 1 pack of RBC. Serum urea, serum creatinine were normal. RBS was 200 on day 1 and 153 on day 8. Viral markers were non-reactive. Urine examination was normal and 24-hour urine protein was 248 mg per deciliter. Serum electrolytes were normal and serum calcium, she had hypocalcemia and calcium supplementation was given, sir, injection calcium gluconate. So it increased from 8.9 mg per deciliter on day 4 to 9.8 on day 16. Biochemistry panel, creatine kinase, procalcitonin, G6-PDH activity, vitamin D3, magnesium, phosphorus, serum LDH and parathyroid hormone were normal. Blood group was B positive. ANA profile, U1 RMP was positive and anti-Smith antibodies were strongly positive. Rheumatoid factor was negative. Ultrasound abdomen, grade 1 fatty liver, left renal calculus, 4 mm calculus in the inferior pole. Chest X-ray.
It is a frontal chest radiograph. The patient is in rotation. The cardiac shadow is within normal limits. Bilateral lung fields appears clear. Both domes of diaphragm are well outlined. Bilateral costophrenic angles are clear.
So normal X-ray. Histopathology, light microscopy. We see a subepidermal blister with neutrophilic infiltrate and scan.
Your microscopic picture of that, your diagnosis is first is something you written. Would you like to exclude or like to still continue with that histopathology?
Subepidermal blisters are usually seen in bullous pemphigoids. But she was on prolonged steroids and Dapsone, but still she did not improve.
The histopathology is ruled out.
You must have pemphigus vulgaris is not possible.
Sections show skin with a central subepidermal blister containing neutrophils and scant fibrin. The adjacent epidermis is intact with mild papillary dermal fibrinoid necrosis at the edges of the blister. The dermis shows otherwise unremarkable collagen and adnexal structures without significant eosinophilic infiltrate or vasculitic change. So these are the direct immunofluorescence image. Direct immunofluorescence demonstrate strong continuous linear deposition of IgG, IgA, IgM and C3 along the dermoepidermal junction. This is the DVD. Next picture depicts salt spray technique showing immunofluorescence on the floor of the blister. Final impression, based on histopathological and DIF features, the final impression was bullous systemic lupus erythematosus.
Show the band in your picture. Oh, you are not marked it, that's why I am asking.
Base pattern is positive. That means that antibodies are against collagen 7.
Final diagnosis, based on clinical, histopathological and DIF features, the final diagnosis was established as bullous systemic lupus erythematosus. Treatment given, injection dexamethasone 8 mg for 7 days in the morning, injection dexamethasone 6 mg IV for 2 days in the night, injection ceftriaxone 1 gram intravenous twice daily for 7 days, injection Pantop, tablet Dapsone, tablet hydroxychloroquine, and antihistaminics with supplementation of iron, calcium and multivitamin. Topical antibiotics and condensed compressions were given. Patient showed significant improvement and was discharged with appropriate follow-up advice, and patient was advised to review after 7 days. Discharge medications included tablet Vizolone 40 mg once daily with hydroxychloroquine, tablet Dapsone, calcium iron supplementation and Zytigel with topical antibiotics. Follow-up. A week later, patient presented to the dermatology OPD with new lesions over the right breast for 1 day with pain. On examination, erosions with pus noted over the inferior part of the right breast. Old lesions over the body were healing with hyperpigmentation. Recurrent flares and escalation. Despite treatment with high-dose corticosteroids, so multiple flaccid bullae were noted over the inferior. So few erosions were noted over the inferior quadrant of Despite treatment with the high-dose corticosteroids, the patient had recurrent flares. Rheumatologist consult was taken for further management. Injection rituximab 1 gram was administered in 2 doses 2 weeks apart. Patient achieved remission with no new lesions. Old lesions healed with mild hyperpigmentation. Continued dermatology treatment. Advised regular follow-up in the dermatology OPD. Discussion. Bullous SLE is a rare autoimmune subepidermal blistering disease occurring in less than 1% of patients with SLE. The diagnostic criteria by Kemiza and colleagues: systemic lupus erythematosus diagnosis based on the American Rheumatism Association, blisters predominantly but not exclusively in sun-exposed areas, histopathology compatible with dermatitis herpetiformis, evidence of antibodies to type 7 collagen via direct immunofluorescence or indirect immunofluorescence on salt split skin. Linear or granular deposits of IgG, IgA and C3 at the DEJ on DIF. Gemon and Brigman as well as Yell et al. Proposed a broader definition subdivided bullous SLE into 3 types. Type 1, reactivity against type 7 collagen. Type 2, with anti-DEJ reactivity without anti-type 7 collagen antibodies. And type 3, bullous SLE, characterized by epidermal binding on salt split technique. In our case, diagnosis was challenging because the patient had multiple complaints with long duration of history. Lesions initially mimicking pemphigus vulgaris or bullous pemphigoid clinically. Based on clinical, histopathological, immunological and classic DIF features, final diagnosis of bullous SLE was established. Positive Smith and RNP antibodies, recurrent oral ulcers, arthralgia, fever, anemia supported the diagnosis of systemic lupus erythematosus. Despite high-dose corticosteroids and Dapsone, she developed recurrent flares, indicating refractory disease. Rituximab, administered in 2 doses 2 weeks apart, resulted in sustained clinical improvement. This case highlights the importance of early skin biopsy, with DIF maintaining a high index of suspicion for bullous SLE in recurrent bullous eruptions and considering steroid-sparing biologic therapy in refractory cases.
Mucosal type of whatever nature. The second one is an SLE presentation, not recurrent after of that nature, which can be little identified in the OP itself. 2. This patient is presented with arthralgias, anemia, and burning mouth recurrent syndrome of ulcers of crops and crops everywhere. That should make one to think, is it a systemic immunological disease of SLE with little abnormal presentation of skin, which should be solved by the dermatologist by immunofluorescence technique. And there is some amount of involvement of the kidney also. I hope we should subject her to kidney biopsy for evaluation of staging of the kidney. No problem.
A rare case of surgically corrected PDA from Department of Cardiology, presented by Dr. Girija Sindhu and moderated by Dr. Vivekananda.
Chief complaints of
Shortness of breath grade 1 since 4 months, episodic palpitations since 4 months, and hemoptysis since 3 days. History of presenting illness. Patient was apparently normal in 4 months. He had breathlessness of grade 1, which has gradually progressed to grade 3 over the past 1 month, which is not associated with orthopnea or PND. He had complaints of episodic palpitations since 4 months without any aggravating or relieving factors. Complaint of streaky hemoptysis 3 to 4 episodes per day. No complaint of chest pain, easy fatigue, growth retardation or fever. History of similar complaints in the past since 6 years of age. He had recurrent URTI in the childhood. No history of any diabetes, hypertension, epilepsy, CKD, CLD or any CAD. Personal history, patient takes the mixed diet, sleep and appetite normal, regular bowel and bladder habits, not a non-smoker or alcoholic. Family history is insignificant. General physical examination, patient is conscious, coherent, ill-built and ill-nourished, no para-visceral cyanosis, but rubbing is present and no lymphadenopathy or pedal edema. Vitals at the time of presentation, temperature is afebrile, pulse rate 88 beats per minute, regular rhythm, normal or limit, no radial or radiofemoral delay. Blood pressure 110/70 mm mercury in the right upper limb recorded in supine position. Respiratory rate 20 per minute, abdominal thoracic type. Coming to the saturation, in upper and lower limb, saturation is 100% and 98%. On exercise, lower limb desaturation is present of 91%. Coming to the CVS examination, inspection, shape of the chest is elliptical and bilaterally symmetrical. Apex is visible in the left fifth intercostal space at mid-clavicular line. No epigastric pulsations, no visible sinuses, scars for dilated veins. Palpation, apex is palpated in the left fifth intercostal space at the mid-clavicular line, which is diffuse type of apex. Palpable P2 at left second intercostal space, no parasternal heave or thrill. Percussion, left liver dullness in the right sixth intercostal space in the mid-clavicular line. Left heart border corresponds to the apex and right heart border is 1 cm from the right sternal border. Left second intercostal space dullness is elicited. Auscultation, second heart sound is heard and pansystolic murmur is heard at the left second intercostal space, best heard with the diaphragm of the stethoscope without any radiation. Coming to the provisional diagnosis, cyanotic congenital heart disease with patent ductus arteriosus with left to right shunt with the severe PAH. ECG, it's a 12-lead standardized ECG.
Wait, go back to your diagnosis and your clinical finding. You had a pansystolic murmur and your diagnosis is very severe PAH with left to right shunt, probably patent ductus. Am I right?
ECG, 12-lead standardized ECG in sinus rhythm beats 80 to 86 beats per minute and regular rhythm. Echo, no RWMA, good LV systolic function, D-shaped LV, dilated RV with the PDA left to right shunt of 18 mm, severe PRPAH with RVSP of 98 mm mercury, IVC normal and collapsing and no PE clot or vegetations. This is the video of This is 2D echo of this patient in aortic short axis view, showing PDA with left to right shunt. It is measuring about 18 mm and this is the image of severe tricuspid regurgitation. Chest X-ray.
Why I asked you that question of your pansystolic murmur? It is nothing to do with the PDA. Why? Because when you have pulmonary arterial hypertension of that magnitude, PDA will become silent. No murmur will be present. The murmur should be your tricuspid regurgitation. You mentioned something, right? Parasternal percussion is 1 centimeter beyond the sternal line. That means there is a gross right atrial enlargement.
It is a frontal chest radiograph. The trachea appears to be in the midline. The pulmonary conus appears prominent. The central 1/3 of the pulmonary vessels appears dilated. The compensated hyperinflation noted in the right lower zone, causing the flattening of the right dome of the diaphragm. And the left castophrenic angle appears hazy, possibly due to mild pleural effusion or pleural thickening. and the right claustrophrenic angle appears clear. Both domes of the diaphragm are well outlined.
Investigation, CBP normal, LFT is normal, RFTs and electrolytes were also normal. PGINR were within normal limits. Lipid profile is also normal. We have done a right heart cath study which shows saturation in the aorta was 97.4% with right atrial saturation 74.9%. Right ventricle is 76.6%. Pulmonary artery 88.4% with QP of 5.46 liters per minute and QS of 2.93 liters per minute and QP-QS ratio of 1.9:1. Pulmonary vascular resistance is 2.7 Wood units and systemic vascular resistance is 5.9 Wood units with a ratio of 0.45, which is impression is PDA with bidirectional shunt predominantly left to right. Treatment given to the patient, it is tablet Dider plus 10/25 per oral 24th hourly, amblysantal with tadalafil 24th hourly and injection Tranexa 500 mg IV 12th hourly. Pulmonology consultation was taken in the view of hemoptysis. They advised repeat CBP and sputum cultures with Tranexa 500 mg IV 8th hourly, Piptas 4.5 grams IV 8th hourly and doxycycline 100 mg BD. CT aortogram image.
Why should you have a pulmonology consultation in this case when your diagnosis is PDA with a bidirectional shunt? And have you mentioned the quantum of shunt?
Yes, sir.
How much?
1.9:1, sir.
No, my question is it 2 cardiac output shunt or 1.5 or 3 like that volume shunt? Number 1. Number 2, what is the quantum of pulmonary arterial resistance versus pulmonary arterial pressure?
0.45, sir.
With your quantified pulmonary vascular resistance, the bidirectional shunt is possible or predominantly you need a node shunt?
Predominantly
because you have mentioned that there is a severe tricuspid regurgitation, which amounts to the pulmonary arterial pressure nearing to the top 2/3 of the systemic pressure. Am I right? And still there is left to right shunt.
Predominantly, yes, sir.
Therefore, is the chance of that phenotype going now and then to the left heart dysfunction and consequent pulmonary edema and strict hemoptysis like that of mitral stenosis?
Yes, sir.
Then what is the necessity to defer for pulmonary consultation and hemoptysis of cardiac nature unless there is a clue for you to think that it is a pulmonary in origin? Sticky. Answer.
Hemoptysis in this case is a very alarming symptom because right from the starting, this patient is having predominantly bidirectional shunt and sometimes predominantly left to right and sometimes it is bidirectional. But if it is predominantly right to left, then patient will have differential clubbing, differential cyanosis, and there will not be any cardiomegaly and silent chest will be there and replaced by Graham steel all the fluorides is not there.
When they occur, hemoptysis is unusual.
Hemoptysis is one of the most common cause of death in Eisenmenger syndrome. The patient goes in Eisenmenger stage, then hemoptysis can occur because of polycythemia leading to pulmonary thrombosis and infarction. Hemoptysis is one of the most common cause of death that is documented in Paulwood series after shunt reversal. So in this case, symptom of hemoptysis is very alarming. That means patient is going into transition from predominantly left to right or bidirectional. Is it a transition stage to the right to left? Is a borderline PH. Very difficult to operate at this stage, but Saab did a good job.
Because cardiothoracic surgeon doesn't take apart the moment bidirectional shunt unless unidirectional left to right. Anyhow, right to left, no question of taking it off. And the patient probably had come in the right time for the right doctor. Otherwise, you could not have been taken outside. A bidirectional shunt is a nightmare because they may bleed like hell from the pulmonary vascular tree and the pulmonary venous component of it, which cannot be controlled. Your expertise, tell us.
There is a reversibility as proven in the cancer study. So there is
No, sir.
only the oxidation test only they found that the short test.
Pulmonary hypertension in left or right shunt.
Nitric oxide test, sir.
Drop. Per catheter.
CT
Reverse.
CT aortogram.
CT aortogram sagittal section showing communication between aortic arch just distal to origin of left subclavian artery and pulmonary canal seen, which represent patent ductus arteriosus.
You are showing under heart. Don't be tremulous.
Zoom.
This is the communication.
Wow. Now comment as a radiologist, the component of ductus. How old is he?
21 years, sir.
Yeah. Okay. It is similar in dimension to the pulmonary end and aortic end. That is accounts to a aortopulmonary window like, but not window because the length of it is almost more than 1 centimeter and above, which excludes aortopulmonary window.
CTVS consultation was taken and sir advised PDA ligation.
The question now is, he needs cardiopulmonary bypass, can it be done without bypass as a resident?
No.
Yes or no?
No, sir.
What is the reason? Because PDA can be ligated without, that was done even before the invention of cardiopulmonary bypass, PDA ligation with the lateral sternotomy. Okay, simple way.
Because of bidirectional shunt and severe.
Direction అయితే డాక్టర్ సార్ మీరు చెప్పండి.
In this case, it is a hypertensive PDA. The angiogram PDA is very big compared to the aortic size. Ideally, it is a case for surgical closure of the PDA and bypass. So, because of the size of the PDA, so we actually planned for ligation only, thinking that there is a differential compliance of the vessels there in the PDA area, both PDA, pulmonary artery, and the aorta have different compliances. So all the secondary morphological changes are mainly due to the hypertension. So the cause is the hypertension. So if you control the hypertension by the controlled vasodilatation and the hypertension, controlled hypertension, we can have the normal morphological features so that the size of the vessels come down and we want to, then we can ligate the PDA. Same thing we did on the table, the ascending aorta, PDA, the pulmonary artery are huge size, then we, with the help of the anesthetist, we have controlled hypertension, come down to 60 pressures, then we ligated the PDA. With the help of the clamping the ascending arch of the aorta. So once we partially clamp the arch of the aorta, still control the pressures, and then we ligate the PDA. The only decision to take the PDA ligation is the size of the length of the PDA. We thought this length is enough to triple ligation of the PDA. We did it, and immediately after ligation, the pressures are automatically gone because of the shunt closure.
You first ligate towards the end of the aortic component or the pulmonary component?
So you should be more pressure area we ligate the aortic side, because once the pressure is under control to 60, usually we can easily ligate the vessel. So only control hypertension only can. Here the most, once I used to do the pediatric surgery, but once I joined the I stopped doing pediatric cases. So because the only reason is the pediatric surgery is becoming a subspecialty. So separate centers have come. So we don't get much referrals, and also we don't have setup here.
Vesicular blood sounds. 2 days ago post-op, status post PDA ligation done, dilated RA artery with no RWMA, good LV function, mild TRPAH with RHP of 40 mm mercury, IVC normal and collapsing, no PE clot or vegetation. Final diagnosis, acyanotic congenital heart disease with patent ductus arteriosus with bidirectional shunt, which is predominantly left to right with good LV function in sinus rhythm, not in CHF. Status post right heart catheterization, status post PDA ligation.
Questions?
Chambers.